Well, thank you very much, and I want to thank Dr. Agarwal very, very much for the opportunity to participate. Also, my first trip to this fascinating country, and I very much appreciate the chance to be here. Let me begin by making some introductory comments about AML. First of all, it's important to remember that the median age has now been shown to be 72 years old. Even in the past year, 14,000 new cases with approximately 10,000 deaths. The disease, of course, can arise de novo or can arise related to prior therapy for malignant or non-malignant disease, or can evolve from an antecedent hematologic disorder such as a myeloproliferative neoplasm or myelodysplastic syndrome. The outcome varies by important prognostic factors. The outcome has improved among younger adults, but not at all among older adults. And I think the most important message of the next 25 minutes of my comments will be the great heterogeneity, both in genetics, in clinical manifestations, and in outcome. There have been a number of victories over the last decades, insights into understanding the biology and prognosis of the disease, anthracycline dose intensification and induction, supportive care improvements that have occurred. There have been refinements in transplantation techniques, and the cure of most patients with acute promyelocytic leukemia, about which we'll discuss much more tomorrow. However, this year actually marks the 40th anniversary since the initial description of what has become relatively routine induction chemotherapy describes in 1973, 40 years ago, and that includes daunorubicin and cytarabine. Now, to give you a feel of how long ago 40 years let me remind you a number of other factors. First of all, this was the year in which the trial of the Watergate burglars began in Washington, D.C. This is the year of the famous meeting between Pope John Paul and Golda Meir at the Vatican. This was also the year that President Nixon announced the accord to end the Vietnam War. And this was also the year in which the new Philippine Constitution named Marcos as president for life. Now, with the conventional induction chemotherapy that hasn't really changed in 40 years, remission rates are approximately 70 to 80% in younger patients and only 40 to 50% in older patients. And of course, these remission rates don't translate into long-term disease-free survival. Well, at 5 years among younger patients, only approximately 40% of patients who achieve remission are cured of their disease, and approximately 15% of older patients. Now, there are many cytogenetic, molecular genetic, and clinical predictors of outcome, but most of these factors predict relapse and not initial response to chemotherapy. These are data from the Eastern Cooperative Oncology Group's consecutive frontline trials, and they make the point that in younger patients there has been considerable improvement over the decades, although outcome is not satisfactory, and there seems to be a plateau in terms of improvement. But among older adults, it is hard to identify any significant improvement in outcome. And if you believe there's some improvement in outcome, most investigators believe it's more likely related to improvements in supportive care. So over the next 20 minutes, I'd like to address these four topics. First of all, talk a little about integrated genetic profiling in AML, then make some comments about new induction and consolidation strategies, talk about the important area of drug discovery, and then mention briefly less intensive treatments for older adults, which I think have really emerged as a new standard of care. First of all, there have been published a number of series of classifications by cytogenetic groups which classify patients into favorable, intermediate, and unfavorable categories. And this kind of a classification, I think, while useful, is, I think, passé. We've now moved in the area of molecular genetics, and we are defining this disease into different cytogenetically and molecularly defined risk groups. And this is much more au courant. And a couple of examples, of course, that, for example, patients with normal karyotype who express the NPM1 mutation but do not express the FLT3 gene mutation previously have been categorized as intermediate prognosis, now are classified as favorable prognosis. And similarly, patients with normal karyotype that express the FLT3 gene ITD, also previously categorized as intermediate, now categorized as adverse. So there's been a shift from patients primarily from intermediate into both favorable and unfavorable risk groups. Now, there are a number of gene mutations that I think are clinically important in everyday practice today, and I think all patients with AML should have these done. These include the FLT3-ITD, NPM1, CEBP-alpha, and c-KIT, primarily the latter for core binding factor leukemias. And here I show you the relative incidence and the impact. There are two that are favorable, NPM1, CEBP-alpha, and two, of course, that are quite unfavorable, FLT3-ITD in primarily normal karyotype AML, and c-KIT primarily in core binding factor leukemia, and actually probably best described in 821, less clear in inversion 16. But there are at least 4 gene mutations that I think are what I call clinically important in everyday practice tomorrow, if not today. And these include IDH1 and 2, DNMT3A, TET2, and ASXL1. Most of these are unfavorable, although the IDH1 and 2 may be unfavorable in normal karyotype AML. They may be favorable in patients with NPM1 FLT3 negative ITD. And this shows you these 4 new novel gene mutations that I think will become critical to be evaluated in patients with newly diagnosed AML. Again, ITD1 and 2, IDH1 and 2, DNMT3, TET2, and ASXL1. And I show here some of the associations that may be present, and again, the influence on outcome. IDH, as I mentioned, in general, has an unfavorable prognosis, I think, in patients with NPM1 negative and FLT3 negative leukemia. But interestingly enough, there are studies now that suggest if a patient is FLT3 positive, FLT3 negative, and NPM1 positive, the additional expression of IDH may confer an unusually favorable prognosis. So is there relevance to these novel gene mutations in clinical practice? Well, novel mutations certainly have prognostic value in AML, including in older adults, although less studied. An integrated mutational analysis can be used to risk stratify patients, and genetic factors influence specific treatments. Currently, this is certainly much more applicable to younger patients, particularly with intermediate risk. Now, here's an example from some data generated from Ross Levine and my other colleagues from Sloan Kettering Cancer Center and from the Eastern Cooperative Oncology Group, again demonstrating that all patients with FLT3-ITD negative disease are not alike. And if a patient has intermediate risk by cytogenetics, normal karyotype, expresses FLT3-ITD, and does not express FLT3-ITD, but does express NPM1 on the top curve, these are patients that look like they have an unusually favorable outcome. On the other hand, if a patient expresses any one of the following TET2, MLL-PTD, ASXL1, or PHF6, they have a very unfavorable prognosis among patients with intermediate risk that are FLT3 negative. And this is also to show you that there are patients that have the double mutant, the NPM1 positive IDH double mutant, again, that seem to segregate into a very, very favorable outcome among patients who are FLT3 ITD negative. And not all patients who express FLT3 ITD are actually as unfavorable as others. And in fact, you can discriminate a group of patients that express the FLT3 ITD that have a much poorer prognosis than others. So patients that express the FLT3 ITD that express CEBP alpha, for example, don't have an excellent outcome, but certainly have an outcome that is not as unfavorable as those patients that have TET2, MLL-PTD, trisomy 8, or DNMT3A. So it's important that one recognize that you can now risk stratify patients based on an integrated mutational profiling. And notice in the green curve at the top, there are patients that have intermediate risk cytogenetics that have favorable mutational risks that are actually more favorable with respect to outcome than patients that have